Hello, I'm Dr. Shreya, Assistant Professor of Dermatology, Venereology and Leprosy, Sree Balaji Medical College and Hospital, Chennai. I'm going to be talking about a very common dermatosis, psoriasis. And the specific learning objectives of this lecture would include clinical features, etiopathogenesis, clinical variants, investigations and treatment of psoriasis. The word psoriasis is derived from the Greek word psora, which means itching. Now, psoriasis is a chronic inflammatory disorder affecting the skin and also the small joints like the distal interphalangeal joints. The clinical course is characterized by remissions and exacerbations. And the disease is multifactorial with genetic and environmental factors playing a role in the causation. Now, the age of onset, there are two ages of onset. A first peak between 15 to 20 years of age and the second peak between 55 to 60 years. There is a high familial occurrence, especially with first degree relatives. This is especially true if the disease presents in the first peak, that is between 15 to 20 years. And this disease is seen equally in both men and women. While the exact etiopathogenesis is unknown, there are certain environmental triggers as well as genetic susceptibility which play a role. These triggers cause keratinocyte injury and increased antigen presentation, resulting in increased production of pro-inflammatory cytokines such as interleukin 17, interleukin 12, interleukin 23, interferon gamma, tumor necrosis factor, and interleukin 22. These cytokines cause epidermal acanthosis and abnormal keratinocyte proliferation. So psoriasis basically has increased proliferation and decreased differentiation of the keratinocytes. So basically what happens is the cells in the basal layer normally divide and move upwards to the stratum corneum. And this cell turnover usually takes 26 to 28 days in normal skin. But in case of a psoriatic skin, this takes just 3 to 4 days. That is, the psoriatic epidermal cell may travel from the basal layer to the stratum corneum within 3 to 4 days. There are certain triggering and modifying factors which are known to aggravate psoriasis, common of them being stress, seasonal variation, alcohol, and smoking. Psoriasis is known to aggravate during winter where the skin becomes dry. Certain infections like HIV and streptococcus can aggravate psoriasis. Psoriasis usually remains during pregnancy, but there is a particular type of pustular psoriasis which is seen in the second trimester of pregnancy. Certain drugs like beta blockers, lithium, anti-malarials, and ACE inhibitors can aggravate psoriasis. Now, coming to the clinical presentation, the psoriasis can present with erythematous plaques with silvery white scales. It's extremely itchy, has a bilateral and symmetrical mode of distribution. While any site can be affected, the common sites include the elbows, knees, scalp, and the lower back. Psoriasis has a number of clinical variants, the commonest of them being the chronic plaque psoriasis, followed by guttate psoriasis, flexural psoriasis, erythrodermic psoriasis, and pustular psoriasis. And there are certain local forms of psoriasis, palmoplantar psoriasis, scalp psoriasis, and nail psoriasis. The chronic plaque psoriasis is what I discussed a little ahead. It presents with erythematous plaques with silvery white scales, usually bilateral, symmetrical, affecting the elbows, knees, and scalp, but can affect any part of the body. Guttate psoriasis, the term guttate means raindrop-like. So basically, the lesions present as small erythematous plaques resembling raindrops with minimal to absent scaling and is commonly seen over the trunk and proximal limbs. This guttate psoriasis is commonly seen in children and associated with streptococcal infection. That is, there will be a history of an upper respiratory tract infection. A course of antibiotics is usually enough to treat this condition. Flexural psoriasis, as the term denotes, the flexures are affected. Now, flexures are opposing surfaces. The presentation of psoriasis is slightly different. It presents with erythematous macerated plaques with minimal to absent scaling. Erythrodermic psoriasis. The term erythroderma means erythema of the body, that is redness of the body, involving 90% of the body surface area associated with scaling. Now, erythroderma is considered a dermatological emergency, and psoriasis is a common cause of erythroderma. So, chronic plaque psoriasis or pustular psoriasis, if left untreated, can slowly evolve into erythrodermic psoriasis, which can lead into certain complications like high output cardiac failure and sepsis. Pustular psoriasis. Pustule is a sterile pus-filled lesion. So, in pustular psoriasis, the erythematous plaques can be superstudded with sterile pustules, and these pustules can be seen on normal skin as well. Now, there are two forms: there's the localized form and a generalized form. The localized form of pustular psoriasis presents as three types. Psoriasis with pustules, where a localized psoriatic plaque can have pustules. Then we have a pustular psoriasis with the palms and soles. The palms and soles are involved, and usually the fingertips are spared. And there's a very important form called as acrodermatitis continua of Halepo, where the fingertips are involved, especially the nail plate and the nail bed. So this is seen in the picture towards the right, where there are pustules in the nail bed destroying the nail plate, and there is involvement of the surrounding skin as well. And in acrodermatitis continua of Halepo, there can be destruction of the bone as well. The generalized form of pustular psoriasis, the commonest type is the acute generalized pustular psoriasis of von Zumbusch, which can lead into erythrodermic psoriasis. Then we have the pustular psoriasis in pregnancy, which is known as impetigo herpetiformis. This is seen in the second or third trimester of pregnancy. We have the rarer forms of pustular psoriasis, which are the infantile and juvenile pustular psoriasis, and the subacute annular or circinate pustular psoriasis. The other localized forms include palmoplantar psoriasis, which, like the name mentions, it can involve the palms and soles and is associated with extreme fissuring and scaling of the palms and soles. Scalp psoriasis can vary from minor patchy flaking or scaling over the areas of the scalp to thick hyperkeratotic plaques, which can extend beyond the hairline and also involve the ears and retroauricular area. Now, nail psoriasis can present in the form of pitting, subungual hyperkeratosis, onycholysis, which is separation of the nail plate from the nail bed at the distal side. There's something called as oil drop sign, where there is yellowish discoloration at the distal portion of the nail plate and nail bed, as seen in the picture. Now, coming to the diagnosis, psoriasis it's a clinical diagnosis. Now, there is an important sign known as Auspitz sign. So, where we use a cover slip, a glass slide, or the blunt end of a blade to scrape off the silvery white scales. So these silvery white scales just fall off, and this is known as grattage test. Now, once we scrape off the scales, we come across a glistening shiny membrane known as Buckley's membrane with pinpoint bleeding points. So once the pinpoint bleeding points become visible, it indicates a positive Auspitz sign. A histopathology can be done to confirm the clinical diagnosis, which reveals hyperkeratosis, parakeratosis, decreased or absent granular layer, acanthosis, regular elongation of the rete ridges, and sometimes the distal portion of the rete ridge may get fused, resulting in the appearance of a camel foot. There can be dilatation of the dermal papillary capillaries and formation of Munro's microabscesses, which is a collection of neutrophils in the stratum corneum. Now, as I've already mentioned, psoriasis can affect the skin and the small joints. So, radiological examination can be done to rule out psoriatic arthritis. Now, treatment involves general features like if there are any triggering factors, we ask the patient to avoid the triggering factors. If there are any drugs, try to change the drugs. And most importantly, the skin is extremely dry. So, we advise the patient to use moisturizers, to use emollients to maintain the skin barrier. Now, depending on the severity of involvement, we can go in for topical or systemic therapy. If the psoriasis is very mild, we can go for topical therapy, and the common treatment involves topical corticosteroids. Other topical therapy includes topical calcineurin inhibitors like tacrolimus and pimecrolimus, topical vitamin D analogs like calcipotriol, topical coal tar, topical anthralins, topical keratolytics like salicylic acids. In case of nail psoriasis, topical retinoids like tazarotene and intralesional corticosteroids can be used. There are newer analogs used for newer topical molecules that are used in the treatment of psoriasis. They include tofacitinib, which is a Janus kinase inhibitor, and crisaborole, which is a phosphodiesterase 4 inhibitor. Now, if the psoriasis is extensive, not responding to topical therapy, or it's impeding the quality of life, then we can go in for systemic therapy. The most common therapy used is methotrexate. Now, methotrexate is given at a dose of 0.2 milligram per kilogram as a weekly dose. It is not a daily dose. It is given as a weekly dose. Other treatment options include acitretin, cyclosporin, mycophenolate mofetil, apremilast, tofacitinib, and in case of pustular psoriasis and erythrodermic psoriasis, a course of oral corticosteroids can be given. Other treatment options in psoriasis include light therapy in the form of narrowband ultraviolet B phototherapy, psoralen plus ultraviolet A therapy, excimer laser, and photodynamic therapy. Newer treatment options include biologicals in the form of TNF alpha inhibitors like infliximab, etanercept, and adalimumab, interleukin 17 inhibitors like secukinumab and ixekizumab, and interleukin 12 and interleukin 23 inhibitor like ustekinumab. Thank you. To summarize, psoriasis is one of the common dermatoses presenting to the dermatology outpatient department. It can affect any age and any gender. It commonly presents with silvery white scales on an erythematous plaque and can affect any part of the body. It is associated with severe itching. Now, psoriasis is an immune-mediated disorder and hence cannot be contagious. There's a lot of myth stating that psoriasis can spread from one person to another, but psoriasis is an immune-mediated disorder and is not contagious. Now, in the modern era of medicine, there are a lot of treatments available to keep psoriasis well in control. So, in addition to controlling the triggering factors, psoriasis can be treated with moisturizers, topical corticosteroids, and systemic therapy such as methotrexate, cyclosporin, or acitretin.